The challenges of kidney cancer in 2019 and going forward are we have a change from our TKI era to our immunotherapy era, and our immunotherapy era has been complicated already by 3 large pivotal trials that have led to FDA approval: Ipi-Nivo, Pembro-Axi, Avelumab-Axi. Each of those in comparable treatment populations, but not compared with each other in previously untreated patients. Ipi-Nivo and Pembro-Axi have both overall survival as well as objective response rate and progression-free survival improvements when compared to sunitinib. Avelumab-Axi doesn't yet have survival advantage, but does have progression-free and ORR changes when compared with sunitinib. All of these have pretty typical side effect profiles, as you would expect from I-O or TKI. There doesn't seem to be any unusual added TKI toxicity when you're combining a TKI with an I-O. Good news. So you don't have to learn about new things to manage patients. And the big challenge is, how do you choose? So in my practice, the conversation comes down to what are the goals of the patient? What are the potential comorbidities that the patient has that could limit benefit through adverse events? And the fourth is, does the therapy need to be generating a response sooner as opposed to later? So how do you think about that? If you think the complete response or durable response is a goal for your patient, then I think Ipi-Nivo and Pembro-Axi are the choices. Although Pembro-Axi and Avelumab-Axi have response rates that are objective response and CRs that are a bit lower. If you think that the person has comorbidities that make them immune at risk, you might want to use Pembro-Axi or Avelumab-Axi, because Ipi-Nivo certainly does have more immune-related adverse events. If one's thinking about rapidity of response, although they've not been compared, it does appear that the rapidity of response is faster when you add a TKI to an I-O than when you give I-O together. So I think what we're learning is that we have many riches, and now we're having to tailor those to the patients that we see. You would say, well, can't there be a biomarker to pick out the winners? The answer is no. PD-L1 plus or minus does not help us choose. There are prospective biomarkers looking at angiogenesis profiles and immunologic profiles, which are helpful, but not yet validated, so can't you really use those? In my practice for good prognosis patients, we're still resecting the primary tumor. So even though the Carmina trial said in the poor risk patients, cytoreductive nephrectomy is not helpful, in the better prognosis patients, we still do that. And the amazing thing is that we now expect kidney cancer patients to have quite prolonged survival, whether it's good, intermediate, or poor prognosis, in contrast to a decade ago, with some of these people leading lives without active kidney cancer, which is, for 2019 and beyond, quite extraordinary.